When it comes to heart surgery, more deaths occur outside of the operating room than in it. Dr. Daniel Engelman, a cardiac specialist at Baystate Medical Center, is among a small group of medical professionals who believe that a system long thought impossible to create could be developed to change that. Engelman is among a team that helped to create a new standard for cardiac patients. ERAS, or Enhanced Recovery After Surgery, and since the information was published online in the Journal of American Medical Association Surgery last month, it's gone viral. Engelman joined me in the studio to discuss.
ERAS, which is Enhanced Recovery After Surgery, is a movement that's an international movement started mostly in colorectal surgery about 10 or so years ago. And what they decided was that the standard way of doing things surrounding the pre-op as well as the post-operative management of patients around colorectal surgery probably was wrong, and that a lot of the nuances could be eliminated and they could speed up recovery and get better outcomes if they focused their attention on such things as eliminating the diet restriction right before surgery and the bowel preps and some of the pain management issues and a whole host of different things that were not related directly to the surgery but in the perioperative time frame, the before and after surgery. So this started around 10 years ago and it was in colorectal, and then other fields, general surgery, liver surgery, biliary, pretty much every other area of surgical specialty started looking at it and saying, you know what, we can do a better job also preparing our patients for surgery as well as healing them from the surgery.
But cardiac wasn't touched. Why?
The cardiac wasn't touched because it was always felt to be too complicated. They said that in cardiac surgery we use a heart-lung machine and there are all these bleeding issues, and the patients are in the hospital for up to a week, and there's so many providers. It was too complicated, and that there was nothing really left to do. It was too different than all the other specialties. So myself and a couple of other surgeons who spend a lot of time thinking about perioperative medicine decided that may not be true, and that we really needed to see if we could get best practice evidence-based guidelines, and we looked to see what was out there, and it had never been written.
And so I think you told me when we were speaking prior to this that 80% of patients who die because of cardiac surgery do so after the actual surgery. Is that correct?
It's thought that a perfect surgery will have a perfect result, and that when we go to our medical meetings, we spend a lot of time looking at the best possible way to fix patients' hearts and to do bypasses and to perform the surgery. But it turns out when you look at preventable morbidity and mortality, 80% of that occurred either from an inadequately prepared patient before surgery or during the post-operative time frame, and a process in which the patient didn't get either the right medications or the right treatment in a timely fashion, or was sent maybe to the wrong place post-operatively, or wasn't brought back in a timely fashion for a complication. So 80% of the complications occurred outside of the operating room that resulted in either morbidity or mortality following cardiac surgery. And yet we spend very little time at our national meetings looking at that area to try to optimize it. So between that and this whole ERAS movement that was in every other specialty, we decided to get together and look at the evidence, and we spent a good year and a half looking over what was there, what existed, what didn't, and writing guidelines.
And so now those guidelines are out, making some waves, catching some attention, because as you said, people didn't think that it was possible. There's about 25 of the steps or 25 areas that you're looking at, right?
Recommendations, basically.
And so what's one or two? I mean, I know there are lots, but what are one or two that stand out to you?
Sure, so we divided them up into those which are best to do before surgery, those right after surgery or surrounding how you might finish your surgery, and then those in the post-operative stage of right when you're completely done with the surgery. The important ones, I would say, can be grouped together. So the preoperative ones are prehabilitation, which 2 years ago I didn't even know what that meant. We all know what rehabilitation is. That's getting yourself kind of back to your baseline, where you were before the surgery, right. But prehabilitation is actually getting you in shape for surgery. And it turns out in every other surgical specialty, they've proven that if you optimize yourself before surgery, you'll have a better outcome.
in shape before surgery. So I want to pause on that for a second, because if someone has a heart condition, how can you get them in shape before surgery? They're already hurting if they get to you, right?
So this is sort of one of the disruptive things that we kind of stumbled across and we have now recommended. So let's not talk about the patient who is dying of a heart attack and needs emergency surgery. That's not the patient we're talking about. It turns out probably 75% of patients are elective for cardiac surgery. They go home, they're diagnosed with their disease, either valvular, aortic, or coronary disease. They go home and then come back at some future date for their surgery. That could be 2 days or could be 2 months from then, depending upon scheduling and preferences. It turns out that those patients should be optimized. So how would you optimize someone in, let's say, a 3 to 4 week time window? A couple of them are very simple and would seem obvious to you. Smoking cessation. It turns out there's definitive data that if you quit smoking before surgery for at least 2 weeks, you will do better. So you need to be enrolled in a smoking cessation program. You'll get off the ventilator quicker, you'll walk quicker, and you'll go home quicker, and you'll have less post-op infection. Hazardous alcohol use. If you are drinking too much, that needs to stop before surgery or you're going to have post-op complications. Glucose control. If you're a diabetic, your glucose needs to get under control prior to surgery, or undiagnosed diabetes. Malnutrition and frailty and deconditioning, that's sort of one big group. And those are patients who don't exercise, have very little muscle mass. They probably will do better with a very limited exercise regimen. I'm talking about a little walking.
Right, you're not sending them out to go run the Boston Marathon.
Absolutely not. What they do is they go to the same post-op rehabilitation people, but they see them instead before surgery. So they're monitored by experts who know what to look for. They're not putting them on treadmills necessarily. They're literally putting them in a chair and having them lift a little bit of weight just to build a little bit of muscle. And at the same time, they're coaching them in proper nutrition, building up their nutrition. All of that's the pre-op.
And so in terms of post-op, people have the surgery, it's gone successfully, you're sending them home. What's 1 or 2 things they're going to do now that they wouldn't have done 5 years ago?
So one real big focus, which everyone will understand, is to try to get them to use the least amount of opioids as possible, narcotics. And everybody pretty much knows the reason why opioids are a problem after surgery. And the data.
The addictive quality, is that what you're referring to?
The addictive quality, and it turns out that if you're still taking opioids 1 week after your surgery, you have a 10% chance of being a long-term user of opioids. 2 weeks out, you have a 20% chance. So we need to do whatever we can to figure out why patients still need opioids after heart surgery, either find a alternative or fix that problem. So what we've done is, from the start, we've used what we call multimodal analgesia, and that's a standard across all enhanced recovery programs. And that's using drugs other than opioids. And there are a lot that exist, different ones for different specialties, but just the simple one of around-the-clock Tylenol lowers the amount of medications you need for pain. Regardless of whether you have pain, every 6 hours, Tylenol maximal dose for the first week or 2 after heart surgery. That's a simple step, very little side effect, easy.
So interesting full circle connection here. Your father, Dr. Richard Engelman, developed Fast Track, which I understand is sort of the foundation for what you've done now here with the ERAS. Have you talked to him about this?
Sure.
What does he think?
So some would say it's not a coincidence. I'm not sure. Who knows? But it was about in 1994 that my father first came up with the idea that patients could be fast-tracked, rapidly brought through heart surgery and sent home in under, at the time, the average length of stay was probably 10 days to 14 days. And he came up with the idea they could leave in 5 to 7 days, which was unheard of at the time. And he did a lot of the components that we're using, not all of them, but at the time it gained international traction, and it sort of led the way to the enhanced recovery movement around the world in all the other specialties. So we were the first to start it, but then the last to kind of bring it full circle back.
Is it too soon to say how many lives you think will be saved by now with this cardiac ERAS?
Well, lives are, it's hard to say. One of the other areas that we're really doing outstanding work here at Baystate in is preventing lost kidneys. So we like to count the number of kidneys we've saved. And one of the ERAS guidelines suggests to use these new novel biomarkers to detect kidney stress before kidney injury, because kidney injury affects up to 20 to 30% of patients after cardiac surgery. But here at Baystate, it affects probably only 1 to 2% of our patients, because we are on the cutting edge of using these novel urinary biomarkers to detect stress before injury. So even just that little intervention probably has saved hundreds of kidneys, and that over time prevents a lot of long-term morbidity and mortality.